is 4 years due to mental illness. Disability adjusted life years, it means like a premature retirement or disability due to an illness. So this is Abu Dhabi. If you're not familiar with UAE map, it's the capital and the large city and the second populated after Dubai. It's worth mentioning that Abu Dhabi is divided in 3 main regions, the center or the main region and the eastern region where Al Ain service or Al Ain hospital located, and the western region. Although the western region is the biggest, but is the least populated because it's mostly covered by desert. But I wanted to highlight that there is no mental health service in the western region. So if people want to seek or to see a psychiatrist, they have to drive around 200 to 400 kilogram to get to see their psychiatrist. So the main region is the most populated. The total population is, we're approaching 3 million people in Abu Dhabi. 20% of them are only UAE nationals. So this is again another challenge on the mental health service planning, because you would expect that the government has to look after those majority of community of expats in terms of health insurance and health access. The governance of mental health sector is administered by different health authorities in the country. Now, the Ministry of Health will provide the regulations of public sector, along with, specifically for Abu Dhabi, we have the Department of Health that is responsible for regulation. And we have some health authorities in Abu Dhabi and in the Emirate of Dubai who are responsible for service delivery. According to WHO report in 2015, there is no official approved mental health policy. It does not exist, but mental health is specifically mentioned in the general health policy. Dedicated mental health legislation exists and legal provisions concerning mental health covered in different laws like welfare, disability, general health, and legislations. Our Mental Health Act is a bit old. The last piece was published in 1981, and it's concise, limited. But there is a Mental Health Act that is under review now. Expert here in Behavioral Science Pavilion Sheikh Khalifa Medical City are involved with other experts in the mental health field, with the legal department, to make it launched as soon as possible. So let me explain what is the system or the model of care of mental health service in the Emirate of Abu Dhabi. I designed this graph. So we have the public sector, private sector, and some other sectors. Public sectors, we have 2 hospitals or departments in the main region of Abu Dhabi, which is us, the Behavioral Science Pavilion. We like a standalone hospital that is closed or attached to Sheikh Khalifa Medical City, and the Behavioral Science Institute in Al Ain. And we have recently, in the past few years, some few psychiatrist clinics in ambulatory healthcare centers. We have 3 psychiatrists, one of them a child psychiatrist, rotating in different clinics in different catchments area in the ambulatory healthcare centers. Private sectors, we have some private centers for mental health like Mosley and the American Center, and some private clinics in the general private hospitals. Behavioral Science Pavilions has 126 beds, and Al Ain has 33 beds capacity. And I'm going to highlight this in the resources and bed capacity. So in all Abu Dhabi, we have 159 beds, and there is no inpatient service in the private sectors. The other one, the National Rehabilitation Centers, it's kind of semi-private. It's only for UAE nationals and only treat substance misuse disorder. It has outpatient and inpatient services. So I'll focus on BSB, not because it's hosting the conference or I'm working here, but it's really the main and the central, the largest and the referring center for mental health services in the Emirate of Abu Dhabi. It's the only inpatient service inside the main region. It provides bedside consultation, 24/7 services to other governmental facilities, three main hospitals. One of them is maternal hospital. We have outpatient specialty with wide spectrum of a specialty, child and adolescent, geriatric, addiction, forensic psychiatry, outpatient clinic. We have daycare program for severe mental disorder and disabled patient. And we have home care or visits for patients who are lacking insight or socially disadvantaged. Here is a recent report of the caseload in the Behavioral Science Pavilion. We received around 40,000 outpatient visits per year, 1,600 admission per year, and we conduct around 5,000 home visits every year. Our client mostly from Abu Dhabi main region, and then from middle region, from Al Ain, from other Emirates, and this is the Western region, which I already told you that they don't have a psychiatrist there or any psychiatric care, so they have to travel around 200, 400 kilometers to reach us here. Despite the healthcare system is new, relatively new in the Emirate, I mean, this place is established in 1995, but we still believe that we have grown very fast. We have subspecialty, some established rehabilitation service, home care, daycare. Yet we have a lot of gaps and challenges to meet the international standard. With regard to gaps and challenges, I will talk about mental health budget and financing, resources, manpower, what is the system and current model of care, what are the specialized services we are lacking, and what is our future plan. It's a quite old report. It's in 2010, but WHO have sent a reviewer at that year to review the mental health service in the Emirate of Abu Dhabi, and it's the only report since then. We don't have we didn't have a subsequent visit since then. Regarding healthcare budget and financing, despite that the country is classified as a high-income group country, UAE or the Emirate of Abu Dhabi is spent 2% only of the total healthcare expenditure to the mental health. And there is no separate budget for mental health. It's within the budget of the general hospital. The WHO has produced a detailed document about mental health financing and what is the correct way of financing a mental health. It recommends that from a policy perspective, it's recommended that mental health care should be integrated within general health. But when it comes to budget, it is recommended that mental health as a distinct, separate, identifiable budget under control of mental health planner and policy makers. Where possible, government should attempt to achieve mandatory coverage for mental health either through national tax base or social insurance. So mental health financing in different countries in the world, it's either through taxing, which is 60% of the countries out of pocket, social insurance, private insurance, or external grants that other associations that fund mental health. These are examples. We're 2%, but see other countries, some are 6%, 9%, 5% of the total health expenditure. So this is a graph from benchmarking network from NHS, would say like Wales and Scotland are spending the most on the mental health, around 11, 12%. And again, we are 2% only. Regarding the mental health coverage in Abu Dhabi, mental health disorder is covered in a scheme of social insurance for all UAE nationals who are the minority in both the private and public sector. But when it comes to non-national residents in the Emirate of Abu Dhabi, unfortunately, the healthcare system is insurance-based, but none of the insurance plan or majority of them, they don't cover mental health care. So the Department of Health had came with a plan to provide coverage and ensure full access to mental health service for the expat. So they allow them or they provide them with mental health service in public sector despite their insurance does not cover it, but they have to pay a small amount of co-payment, which is around 10% of the medication cost. And when it comes to inpatient sector, it's a free treatment. If they want to go to private sector, the only method is out of pocket unless they have a special kind of insurance that cover them. Regarding manpower, I'll rely on WHO Atlas in 2017. We have 1.6 psychiatrists per 100,000 and 0.7 psychologists per 100,000. In the Emirate of Abu Dhabi, in public sector, we have 5 child psychiatrists in the Emirate of Abu Dhabi, divided between Al Ain and Abu Dhabi region, and also in the primary healthcare. So number of psychiatrists, the highest is Sweden. They have around 26 psychiatrists per 100,000, and the lowest in English and Wales, around 5 psychiatrists. We still much more below this, we're 1.6. Regarding bed capacity, we have 3 beds per 100,000 in general adult and 0.5 bed in forensic. When we compare to international population, Belgium, they have 170 bed, and English and Wales, they have around 20 beds. We're only 3. In forensic, it's ranging from 14 to 2 beds per 100,000 population. Let's take you now through the healthcare system in the Emirate of Abu Dhabi. This is the document, as well a detailed document about how to organize the service in mental health based on WHO. Mental health care should be provided through general health services and community setting. Large and centralized psychiatric institution should be replaced by more appropriate mental health services. The mental health service in the countries should be divided or should be chosen based on resources. For example, if we're a low-level resources or a medium-level resources, we should design another mental health service compared to country with high level of resources. For example, if there is really low level of resources, the primary health care, the GPs and family medicine should provide care for mental health service, and the specialist psychiatrist should be only backing up, supervising, and treating difficult cases. Where middle-level resources countries, and I think we lie here, you have a mental health care facility, some outpatient, inpatient service, and some community service. Where in high-level country, you'll have like specialized service of eating disorder, treatment-resistant affective disorder, adolescent service, early intervention, and etc. So we lie here in the middle. Again, there is another way to divide the mental health system in the countries based on WHO recommendation. And we have mental health service and primary care and dedicated mental health hospitals. You see here, self-care, informal community care. Informal community care, when you have retired teachers or neighbors looking after mental health patients, this should be encouraged more. Requiring for them is more and in the countries. And then when you go up to the pyramid, the specialized service, more costly, and it's
Dr. Aisha, are you still there?
In countries with low resources, mental health specialists should be used wisely into training and supervision less specialized mental health worker. The integration helps to reduce stigma. A lot of people, they don't like to come to a standalone psychiatric department isolated from general hospitals. And it helps also to overcome the acute shortage of professionals. The integration of mental health service into general health is most viable strategy for extending mental health services to reach population like in Western region. If there is no psychiatrist there, we can establish a way of integration. In regard to integration, the WHO again in 2015 have looked into this, and they said prescription regulation authorize primary healthcare to prescribe and continue prescription of psychotherapy medication, but with restriction. They cannot prescribe for more than 14 days. Some medicine, they cannot go beyond 3 days. And they said that the majority of primary healthcare doctors haven't received official training in the past 5 years. This might have been changed now since we have 3 psychiatrists already there. And this is important point. Official referral procedure from primary healthcare to us do exist, but referral back from us to primary healthcare does not exist. System is still fragmented. It's not coordinated. To establish mental health care in Abu Dhabi, we need to train primary health care staff, have adequate structure, and make sure the psychotropic medications are available. Psychiatrist team in the main hospital should be linked to different primary health care and have a weekly visit maybe to these centers once a week to discuss and treat difficult cases. Maybe we can utilize telepsychiatry in remote areas to supervise and guide. This is my last slide. For a future plan of mental health service in Abu Dhabi, the Department of Health have created a task force group, and Sahha had created a clinical reference group to improve mental health services and model of care. They're working hardly to improve the system. BSB, or the main and the central hospital, our future plan is to focus into opening more services and to integrate in the Sheikh Khalifa Hospital, the main service. We plan to open already a child and adolescent inpatient service there within the pediatric unit. We're planning to open a learning disability service and daycare program for geriatric population, because you all know we don't have nursing home for elderly people. It's really burden on families. So a daycare program might be an option to relieve the stress on families. That was my presentation.
Thank you, Dr. Aisha. Do you want to stop sharing your screen? That would be great.
Okay.
That was really brilliant. Thank you. You had the experience of conference anxiety there. It's always anxiety provoking, isn't it? Where you're trying to make sure that your presentation is sharing, whereas I'm sitting in my kitchen worrying that at the moment, have I got a box of cornflakes sitting behind me? So you did an excellent job there. It was really brilliant to hear about the services. The next presentation, I understand, is a recorded presentation, and it is Dr. Amna Ali Turki, Ali. Dr. Amna is, in fact, the first psychiatrist that I met in Dubai. I visited with my colleague Joe Fletcher to the Al Amal Hospital, where Dr. Amna is a consultant psychiatrist, and she's also the director of the Al Amal Psychiatric Hospital in Dubai. She's leading and directing health services there in close collaboration with my colleagues from Maudsley Health, including Joe Fletcher, who I first met Dr. Amna with. Now, Dr. Amna has a special interest in developing community mental health. I remember her very well describing that, some really quite exciting innovations that she brought to services over there. She works to try and build mental health resiliency and support people with mental illness. So she developed the first community psychiatric department for MOHAP, and she's been providing and leading services for outreach in community mental health, crisis intervention services, and daycare. It's very timely to hear about where you were just talking about the development of services within the UAE. Now, the presentation that she's kindly recorded for us this morning is entitled Pain and Mental Health. So I'm really looking forward to seeing it. So if Norman would cue that up, that would be excellent. Thank you.
Assalamu alaikum wa rahmatullah wa barakatuh. Thanks for inviting me to this conference and for giving me the opportunity to talk about pain and mental health. These are the list of objectives for our session today. And I would like to start this session by reminding you with a real story that happened during the Second World War. Dr. Harry Beecher worked as an army medic at that time, treating wounded soldiers in Italy. When he ran out of morphine, he treated the soldiers with a saline solution. But he didn't mention the switch. In about 40% of the cases, pain subsided anyway. Beecher's findings later played a notable role in theories about pain and the placebo effect, which is a phenomenon in which a person's condition improves even though the medication he or she takes is not designed to heal the problem. And the reverse can happen as well. In some studies, patients who were told they were taken off a powerful pain medication began to feel worse, even though they were still being administered the medication without their knowledge. So there are definite emotional and cognitive influence on pain perception. Pain is the most common reason that people seek medical care. It has a wide range of negative effects, not only for the individual patient, but for the families and the society as well. Both physical and psychological aspects of patient life may be impacted, including ability to work or perform activities of the daily living, sleep patterns, emotional state. Also, the social, family, marital, or sexual relations may be even impaired. The disability and lost work days cause significant direct and indirect healthcare costs for society as a whole. Also, pain found to be the cause of 25% of all sick days taken yearly. So chronic pain also produces lasting harms to the physical health. When someone is feeling pressure, for example, down or frustrated from the chronic pain, this can weaken his immune system, impairs nutrition absorption in his gut, increases vulnerabilities in his cardiovascular system, and decrease reproductive hormones, even can exacerbate premenstrual symptoms in females. It can disturb the nervous system. So we have to consider the famous saying here that neurons that fire together, wire together. This means that repeated painful experiences, even mild ones, tend to increase pessimism, anxiety, can lower the mood, reduce ambitions, and other psychological consequences. So the relationship between pain and depression. Worldwide, patient experiences persistent pain are 4 times more likely to have depression than patients who are pain-free. Survey data showed that patients with depression and chronic pain are more likely to commit suicide than patients with depression or pain alone. On the other hand, between 30 and 60% of depressed patients have chronic pain. Data from the WHO, for example, indicates that over 75% of patients with depression in primary healthcare centers complain of chronic pain symptoms such as headache, stomach pain, neck and back pain, or diffuse unspecified pain. So chronic pain and depression do coexist, but correlation doesn't mean causation. When analyzing the phenomena of comorbid pain and depression, it's so important or interesting to know which comes first. Actually, there are a number of hypotheses, which all seem to be partly correct. Chronic pain can be a symptom of masked depression. On the other hand, chronic pain causes a number of problems that can lead to depression, like trouble sleeping or stress, etc. So it is a classic chicken and egg situation and creates a vicious cycle in which pain worsens symptoms of depression, and then the resulting depression may worsen feelings of pain. So we have to tackle both of them. This slide just shows the pain severity as correlate of depression. Actually, the risk of depression significantly increases with the increase in severity of pain as found by studies. Those with severe pain, for example, were found to be 12 times more likely to be depressed compared to those without pain. And this slide shows the how increased severity of pain is associated with lower depression treatment response rate. So pain impairs depression treatment response. Studies have also showed that those with severe pain are 4 times at higher risk of poor depression treatment outcome compared to those without pain. So comorbid pain and depression may be more difficult to treat than depression alone, and treating only one may prevent remission. The association between chronic pain and depression, however, remains unclear, and in recent years, studies have found considerable overlaps between neurobiology of both disorders. In order to understand this, let's review the neurobiology of pain perception first. As we know that there are 2 types of pain. As this slide summarizes, neuropathic pain, which is induced by a lesion or disease involving the nervous system, whether central or peripheral, and the nociceptive pain that occurs as a consequence of actual or threatened damage to non-neural tissue. Examples of nociceptive pain as illustrated in this slide include post-operative pain, arthritis, mechanical low back pain, sickle cell crisis, and sports or exercise injuries. Examples of peripheral neuropathic pain include post-herpetic neuralgia, HIV sensory neuropathy, and diabetic neuropathy. Examples of central neuropathic pain include central post-stroke pain, spinal cord injury, trigeminal neuralgia, and multiple sclerosis. The middle one, as indicated in the slide, is called the mixed type, which is the chronic pain of mixed etiology with both nociceptive and neuropathic characteristics. It is very interesting to know that the mechanisms underlying chronic pain differ from those underlying acute pain. In chronic pain conditions, central nervous system factors appear to play particularly prominent roles. The characteristic symptoms of these central pain conditions include multifocal pain or generalized fatigue, insomnia, memory difficulties, and higher rate of comorbid mood disorders. Central pain conditions also respond best to CNS neuromodulating agents, such as serotonin, norepinephrine, reuptake inhibitors, and anticonvulsants, compared to acute and peripheral pain conditions that are more responsive to non-steroidal anti-inflammatory drugs, as we know, and opioids. So let's say that you hurt your finger. Nerves in the finger, known as nociceptors, tasked with sensing pain, go into action. They send messages to the spinal cord that pain has occurred. The worse the trauma, of course, the more rapidly and powerfully they fire. The spinal cord then releases neurotransmitters to the brain thalamus, telling the brain that there is an injury. Of course, there is not just one part of the brain that processes pain. The thalamus could forward the message onto other parts of the brain that manages physical sensation, as well as the part that controls emotions, memory, or attention. Neuropsychology of pain. According to imaging studies, there are 4 cortical areas are implicated in pain perception. The prefrontal cortex, the anterior cingulate cortex, the sensory cortex, and the insula, as shown in this slide. The anterior cingulate cortex, as we know, is part of the limbic system and the activity in this area is related to the emotional component of pain, which is the suffering, as well as the motivational motor aspects of pain, which is preparing to do something about pain, including initiation of coping behavioral efforts. Evidence suggests that the anterior cingulate cortex may play a critical role in fear memory acquisition related to pain. And like the anterior cingulate cortex, the insula is a sensory component of the limbic system related to motivation. So the prefrontal cortex will evaluate the meaning of pain and making executive decisions concerning how best to cope with pain. Interestingly, research shows that overall activity in the prefrontal cortex following an acute painful stimuli tends to be negatively associated with the severity of pain. That means that more prefrontal activity is associated with less pain feeling. And that is consistent with the view that the frontal cortex serves a general inhibitory function. So the important question here is, why do people feel physical pain differently? In fact, the differences stems from the way their brains are wired, which can influence pain perception. Not everyone screams or jump to find painkillers when he is hurt or in pain. And this indicates that pain influencing neural pathways must exist from the brain downward. The ascending pathway that we explained is similar in all healthy individuals. And the severity is determined by the activity in the medial prefrontal cortex and nucleus accumbens. These two regions of the brain are conventionally associated with motivation and emotion. The descending pathways converge on the preaqueductal gray prior to modulation of activity in the spinal dorsal horn. The periaqueductal gray in the midbrain and medulla are two important areas of the brain involved in descending inhibitory modulations. Both these centers contain high concentrations of opioid receptors and endogenous opioids. The descending pathways project to the dorsal horn and inhibit ascending pathways transmission. So there are definite emotional and cognitive influence that comes from the descending pathway on the perception of pain. This indicates that the individual can regulate or alter the perception of pain through mental conditioning techniques. For example, like meditation, distraction, visualization, and coping mechanisms other than taking painkiller medications. So, as we know, the activity in the peripheral structures is not sufficient to produce the experience of pain. Pain is perceived when the complex integrated cortical systems are engaged, with or without the presence of activity in the periphery. So in chronic pain, peripheral activity appears to play an important role nmostly in its long-term effects on cortical structures. That's why ongoing nociceptive input can produce neuroplastic changes in the brain, which themselves influence the processing of future nociceptive input. And that which we say, the same saying, neurons that fire together, wire together. That's why patients with either, for example, fibromyalgia or chronic low back pain show augmented brain activity in multiple regions compared to healthy controls. And here I would like to mention the phenomena of the phantom limb phenomena, which illustrates how the mind may retain its ability to experience pain, even after the nociceptors are no longer present. The studies show that patients who have undergone amputation tend to experience the phantom limb sensation far more frequently than people missing a limb congenitally. Also, chronic pain conditions have been shown to be associated with changes in the cortical organization and cortical volume. So having chronic back pain or fibromyalgia have been also associated with decreased gray matter in the prefrontal cortex, which may be associated with a decreased ability to inhibit the experience of pain. As we mentioned, the descending pathway is the inhibitory pathway for pain sensation. So what are the other factors influencing pain perception? Those factors include age. Brain circuitry generally degenerates with age. So older people have lower pain thresholds and have more problems dealing with pain. Gender, as research showed that women have a higher sensitivity to pain than men do. Fatigue, we often experience more pain when our body is stressed from lack of sleep. Disruption of slow wave sleep can increase pain sensitivity. Memory, how we have experienced pain in the past, can influence neural responses due to memory comes from the limbic system. So patients' past experiences, fears, anxieties can play an important role in influencing their pain perception. The monoamine neurotransmitters, including serotonin and norepinephrine, have been studied in molecular mechanisms involving in chronic pain and depression. The descending pathways are monoaminergic, utilizing noradrenaline and serotonin as neurotransmitters. They originate from the same neurons as the central pathway, the RAF nucleus and the locus coeruleus, as we know. In addition to innervating the limbic and prefrontal regions of the brain, they are also involved in the endogenous pain-suppressing descending projections, which we have explained. According to this model, these descending pathways that utilize the monoamine neurotransmitters, when activated, inhibit pain sensory processing. So the descending projections is an endogenous mechanism of pain relief. In depression, for example, the descending inhibitory pathways may be affected, and the modulation of pain through these descending pathways is disrupted, and pain sensations are allowed to ascend to the brain from various organs. So the sensations are not suppressed and are interpreted by the body as pain. This may explain why the pain in many depressed patients has no detectable pathology. And in functional somatic syndromes, such as fibromyalgia and irritable bowel syndrome, the dual action antidepressants have been effective in treating painful symptoms. So how antidepressants work in pain management? As the slide illustrates, that antidepressants work in chronic pain management through descending modulation, as we explained earlier, central sensitization, and peripheral sensitization. The previous theory about the monoaminergic descending pathway explained why antidepressants work in pain. Also, modulating both norepinephrine and 5-HT found to be more effective in pain management than those that have only norepinephrine or 5-HT properties. And the role of 5-HT and norepinephrine in modulation of pain is also demonstrated in chronic pain patients who have no effective symptoms. On the other hand, Patients who receive antidepressants for neuropathic pain may also experience improvement in insomnia and depression, as we found it in our clinical practice as well. It has also been proposed that antidepressants interact directly and indirectly with endogenous opioids to produce analgesia, as explained. It is also proposed that they exert adjunctive therapeutic influences through histamine receptors as well as modulation of sodium channels. It is also important to note here that onset of analgesia with antidepressant generally occurs before the onset of antidepressant effect. And the presence of depression requires higher medication doses. The duration of the onset of response, so for example, depression response usually within 6 to 8 weeks, while pain response usually within 3 to 4 weeks. So it has shorter duration of onset of action. Doses for pain are roughly half of those for depression. So the psychological interventions for pain, the theory behind use of psychological interventions in pain management is that they have primary or initial effects on different pain-related cortical areas. In one experiment, all of the volunteers were subjected to pain stimulus, and researchers found through brain imaging that the thalamus was activated in all of them. But those that were least able to withstand the pain also showed activity in the section of the brain that deals with emotion. Well, a good example of this, I think all of us had this experience, is when babies fall and cry, we try to distract them with our car keys, and it works. When we are anxious or depressed about pain, the pain doesn't go away. In fact, it often seems to get worse. That's not to say that simply thinking happy or the happy thoughts will make pain go away. Sometimes it will, but it's possible that certain people's brains have been rewired or altered to the point that the brain perceives pain even when there is none physically. And these findings about pain could have implications for how we treat it. Rather than just relying on painkillers, it may be better to consider using psychological interventions. Those psychological pain interventions include, as summarized here in the slide, interventions that target the patient's thoughts about pain. For example, the cognitive restructuring, acceptance-based treatment. Secondly, the interventions that target the patient's behavioral responses toward pain, like operant conditioning and motivational interviewing. The third group of interventions that target the patient's sensory experience and ability to achieve states of perceived relaxation and comfort, like the relaxation training and self-hypnosis training. Evidence showed that changes in pain-related cognition, behavioral responses, and ability to alter sensory experience will lead to long-term improvements in patient functioning. So how these psychological interventions may affect the cortical activity. So for example, the cognitive restructuring, which we said targets the meaning component of pain, which has its initial effect on pain through the prefrontal cortex and anterior cingulate cortex activity. Of course, changes in any one component of the pain matrix could alter activity throughout the pain matrix. The second example of the psychological interventions, the acceptance-based pain treatment, for example, involves encouraging patients to focus their efforts away from attempts to reduce the pain, and alternatively to focus towards attempts to achieve valued life goals. And a good example of this is the mindfulness training. The cognitive restructuring targets the content of cognition, while the acceptance-based treatments target the focus of cognition. But both targets cognitions as a way to impact emotional and behavioral responses. The other example of psychological intervention, we mentioned the operant model of chronic pain, is based actually, the operant conditioning. The operant model of chronic pain is based on the understanding that all behavior, including behaviors that communicate pain, for example, verbal reports of pain, repeating verbal reports of pain, guarding, limping, all are sensitive to environmental responses. They increase in frequency when reinforced, can extinguish or decrease over time when ignored, and decrease markedly when punished. Research showing that systematic reinforcement of pain reports lead to increase in pain intensity over time. And this may provide evidence that social responses to pain reports influences both the experience of pain and cortical activity associated with that experience. And the other examples are the motivational interviewing, which is a relatively new treatment approach that has been adopted for use with chronic pain. Motivational interviewing assumes that patients do not necessarily require learning any new coping responses in order to better manage his pain. And instead, this approach requires that the primary problem underlying the maladaptive pain management is a lack of patient motivation for using those coping responses that he already knows about them, but he is not motivated to use them. So according to a motivational interviewing hypothesis, an increase in confidence to engage in adaptive coping and in the belief that such behaviors will lead to positive outcomes, both lead to increases in the chances of improvement. Then we have the relaxation training and the hypnosis. The relaxation training usually involves providing patients with instructions and training in achieving a mental and psychological state of tranquility in a very brief period of time. Improvement in pain experience associated with relaxation training may then ultimately contribute to increase in self-efficacy and sense of control over pain. And that effect will be through the increase in activity in the prefrontal cortex as hypothesized. The hypnosis usually involves first an induction that asking the patient to experience a state of focused awareness, often includes suggestions for feelings of relaxation, like a relaxation training session, or dissociation, imagining being in an interesting or a beautiful place. This is followed by suggestions for changes in emotional or sensory experience. The findings of studies indicate that hypnotic suggestions can affect many different areas of the brain, and that the areas involved vary as a function of the content of the hypnotic suggestions used. So suggestions to change the meaning of pain, for example, by imagining oneself as knowing that the pain does not have to mean that damage is occurring, if it was an effective or given in an effective way, would be associated with changes in activity in the prefrontal cortex, although this has not been very widely studied. There is also research that hypnosis and hypnotic analgesia suggestions influence cortical connectivity. The directions of these effects, whether increasing or decreasing in connectivity, also appears to be related to the type of hypnotic suggestions given through the therapy. So the treatment recommendations for chronic pain and depression comorbidity can be summarized as follows. First of all, we shouldn't assume that one problem is causing the other. And we shouldn't assume that addressing one disorder will fix the other. What we need to do is to screen for depression and anxiety for all patients with chronic pain. Physicians should have a low threshold for referral consultation and treatment for comorbid pain and depression. We need to consider antidepressants for pain and for depression, and not to expect them to fix the problem entirely, as this doesn't always happen. Analgesic effect of dual norepinephrine and 5-HT reuptake inhibitor antidepressants have found to be more effective in acute, chronic, or neuropathic pain. And the presence of depression, as we mentioned earlier, requires higher medication doses. Onset of action in chronic painful conditions is much earlier compared to treatment response in depression. Evidence also shows that collaborative care interventions for pain and depression improves both and leads to better clinical outcome and quality of life. There are a number of studies that suggest the best success in pain management relies on multidisciplinary approach that includes patient education, medications, physical medicine, psychological counseling, etc. For example, when the effect of multidisciplinary pain treatment was compared to with that of treatment by a general practitioner after initial supervision by a pain specialist in a number of patients with chronic non-malignant pain, they found that after 6 months of this multidisciplinary pain intervention, the multidisciplinary intervention group reported a significant reduction in pain intensity and improvement in psychological well-being. Also, quality of their sleep has improved, in addition to other improvements in daily functioning, compared to the second group who just relied on the general practitioner intervention group, which mainly relied on painkillers. So thus, a coordinated approach to pain management often provides the most efficient and cost-effective approach, which leads to patient empowerment and the best clinical outcome. So to summarize, and our main take-home points for today is that chronic pain patients who are depressed are 9 times more likely to be disabled. And comorbid pain and depression may be more difficult to treat than depression alone. Treating only one may prevent remission. Early management of both symptoms prevents central reorganization or plastic changes in the CNS. The collaborative care interventions for pain and depression improve both and are the best and most efficient and cost-effective approach. Thank you very much for listening.
Because so often we know as mental health specialists just how key the role of the mental health components in pain management are, and they're so often forgotten. So it's really important to hear that really comprehensive and well presented run through. So next up, 2 great colleagues from the Al Amal Hospital in Dubai. We have Dr. Rita Eleni Besabes, who's based in the UAE, but Dr. Rita has studied and undertaken her undergraduate qualifications within Ireland, as well as training at the Medical University in Bahrain. She's done her internships in the residency hospitals in Dubai, and she holds a degree in psychiatry from the Arab Board, as well as being a member of the Royal College of Psychiatrists in the UK. She's a general adult specialist currently working at the Al Amal Hospital, and she has a number of senior roles there. She's also been part of the key team who got the JCIA accreditation, which was a really important process I'm fully aware of at the Al Amal Hospital. Joining Dr. Rita in this recorded presentation is Dr. Madonna Haney-Yani, who graduated from Cairo University, and she completed her
Good morning. I am Dr. Madonna Yani, and I am a psychiatrist in Al Amal Psychiatric Hospital in Dubai, UAE. Today, I will be presenting with my colleague, Dr. Rita beside us, and we will be talking about mental health during COVID-19 pandemic from a local perspective. The aim of today's session, background to the study, what do we know from history, the study and its findings, and take-home message. I really hope you enjoy our session today. A background to our study. What was the driver? What had changed? A lot has changed since COVID started. We were used to look like this, but now we look more like this. We needed to adapt our practice quickly to meet our patients' needs. So in Al Amal Hospital, we started telepsychiatry services. We started home delivery of medications, and a helpline was started to help patients or anyone at severe distress to reach out and talk to one of our psychologists. Mental health services were still accessible despite the uncertainty. Patients were still being assessed and followed up, and medications were home delivered. Being part of the inpatient team, myself and all the team noticed that the cohort of patients, the nature of presentations and admissions were different to what we used to before COVID. So a typical case during the pandemic would present with acute onset of bizarre behavior, mood symptoms, along with acute psychotic symptoms. The theme, the nature of delusions and hallucinations were different. And we noticed a rapid response to treatment. All these observations made us curious to understand more about the mental health reaction to the pandemic. So the need for scientific evaluation was evident, and the research team was gathered by Dr. Mu'tasim Qamardeen, our principal investigator, Dr. Amna Turki, our co-investigator, and the rest of the research team members, Dr. Rita, myself, Dr. Cheryl, and Dr. Mohammed. Our research title is Demographics, Nature and Rates of Admissions to a Tertiary Psychiatric Hospital during the COVID-19 pandemic. It's a retrospective observational study. What do we know from history? Allow me to take you in a journey in the time machine just to go and see similar situations where pandemics or earthquakes hit the world, and what was the mental health effects at the time. Learning from history can be a helpful starting point. Major disasters like epidemics, pandemics, natural disasters, and wars can have significant impact on mental health. Can the flu cause psychosis? The Spanish flu pandemic of 1918 affected and resulted in the death of millions worldwide. That intrigued a psychiatrist in Boston Psychiatric Hospital to study more the relationship to psychiatric illnesses. Carl Menninger reported on 80 cases of mental disturbances ranging from 16 to 69 years of age in a 3-month period in 1918. And he noticed of these 80 cases, 48 cases that carried a diagnosis of schizophrenia or other psychosis disorders. 16 were delirium and 16 were unclassified. He observed a high frequency of psychotic symptoms in majority of cases, which led him to ask the question, can flu cause psychosis? Can it be a direct etiological factor into the psychotic symptoms presented? In a follow-up study done 1 to 5 years later, around 80% of the cases had remitted, which really highlights the effect of stress caused by the pandemic into psychosis onset. Can some people be more vulnerable than others? The impact on mental health of older adults was noticed and researched during SARS times. The suicide rate in older adults in Hong Kong was higher in 2003 and 2004 compared to pre-SARS in 2002. The prevalence of post-traumatic stress disorder in Hong Kong was associated with older age and was more noticed in areas where SARS resided. The Great Japan earthquake in 2011. And now we are reviewing a study on the rate of psychiatric admissions, which is similar to our study. If you can follow me here, in 2011, you can notice in the chart from March 11 till April 7, you could see the increase in numbers of psychiatric admissions compared to the same period of time in 2009, 2010, and in 2012 post the earthquake. And if we looked closer into colors, you could see that the biggest surge was in the green color. And it reflects the schizophrenia and delusional disorders. Then COVID hit the world. In March 11, WHO declared COVID as a pandemic. In April 2, confirmed cases topped 1 million worldwide. And in April 10, global deaths due to COVID topped 100,000. And the mental health community started to understand and acknowledge a global need to be assessed in the times of a global crisis. We needed to respond. We needed to answer so many questions. How will the pandemic impact people with psychiatric illness? Can or will it trigger a psychiatric illness in a previously healthy individual? How can mental health professionals meaningfully address the potential increase in need and demand? And the world started to respond. In UK, a study suggested that vulnerable groups require more support to cope with stress. And they suggested CBT and mindfulness approach that they can be really helpful. In Spain, a case series study observed the presence of new onset psychosis. In Denmark, and using self-report scales in the OPD, the findings showed increase in anxiety and mood disorders. In France, a similar study suggested the same. In Australia, findings in ED showed an overall decrease in mental health presentation. And in Italy, a study suggests a decrease in voluntary admission, although not much change in the involuntary admission, maybe a very slight increase even, with an increase in the length of stay. And one of the interesting discussions in this study, especially that it is really similar to our study, that they reasoned the proposed decrease to the extreme fear of contamination and going to hospitals at that time, and the change of threshold in the hospitals to admit patients and occupy beds. And in their discussions, they acknowledged the need for longitudinal studies as they went back again to history, to the time of World War II, where a similar study in Denmark during that time, in 1939 till 1941, and it showed evident decrease in admissions at that time. But in 1942 to 1944, like starting 1 year later, there was a 50% increase in admissions, especially in females with schizophrenia. Another study compared different areas of the world in the same time. It compared Denmark, Finland, Norway, and USA. And in USA, it showed that there was significant increase of new onset psychosis, which emphasized on the need of longitudinal studies and bigger sample size and more global approach into it with multiple countries involved. And we really tried to look if the rate, the nature, or the demographics change of admissions in psychiatric hospitals changed during COVID. We tried to find literature from our area of the world, but we didn't really find, which encouraged us to be the first to look into this study, observing the rates of admissions, nature, and demographics into psychiatric hospital. And Dr. Rita will go more in details to the findings of our study. To sum up our findings, the literature review suggested that at times of hardship, pandemics, wars, natural disasters, mental health can be affected. The reaction can be delayed, and it can differ from person to person, of course, from age to age, and even from place to place, which emphasized, as I said earlier, for the need of more collaboration of the mental health community to have studies from different parts of the world covering different age groups and different services. I want to end my part by saying that it is known that history repeats itself, but I personally prefer Bernard Shaw's interpretation of this saying. He said, and I quote, "If history repeats itself, the unexpected always happen, how incapable must a man be of learning from experience?" We believe that any knowledge, any insight we reach today during the COVID pandemic will definitely be part of the history for future generations. So we better stay curious. We better keep our minds, our eyes open, and keep looking for answers. Now, I will leave you with my esteemed colleague, Dr. Rita, who will discuss more on the findings of our study. Thank you.
Good morning, everyone. Firstly, let me thank Dr. Madonna for highlighting important information from history and current global studies. While Dr. Madonna had her own experience in the inpatient, I was in the emergency department during that time. And when we were expecting anxiety-like presentations in view of the current global situation, we started seeing more and more psychotic type illnesses presenting. And this sparked a curiosity about what was going on. Was the impact of stress in terms of the pandemic coverage worldwide, in terms of the changes to our daily routines, was that affecting psychiatric admissions? So our research idea came to life, and we decided to have a closer look at the people being admitted to Al Amal Hospital in Dubai. And we picked a 3-month period from March 11 to June 11, and we looked at that for the years of 2019 and 2020. And we looked at all of the admissions to the psychiatry wards. Our limitations to the study was the diversion of services that occurred as other facilities adapted their own function to the pandemic. We wanted to look at specific objectives, and we wanted to look not only at the demographics, we also wanted to look at whether these individuals that were being admitted had previous psychiatry history, what kind of diagnosis they were receiving, the type of admissions, the type of referrals, their length of stay, and their COVID status. And we wanted to see if these objectives were different from the pre-COVID-19 era. We'll start off by having a look at the gender. And here we can see that in 2019, there was around 30% females and 60% male. And this remained the same in 2020. We also looked at nationality, and we split it here to UAE nationals and expatriates. And in 2019, it was 40% to 60%, whereas in 2020, we saw an increase in the expatriates that were being admitted. Moving on to the employment status, we had a look at whether the patients that were admitted were currently employed or not. And in 2019, we saw that 30% were employed and around 54% were unemployed. Whereas in 2020, there was an increment to 55% of those employed. Moving on to psychiatry history, we define these as individuals who had previous encounters with mental health services. And in 2019, we saw that 86% of those admitted in that period had a previous psychiatry history, and around 9% did not. Whereas in 2020, those being admitted without a previous psychiatry history increased to around 36%. Then we looked at diagnosis, and here we categorized them according to the ICD-10 coding under the chapter of mental, behavioral, and neurodevelopmental disorders. We saw diagnoses that fall under physiological, substance-related disorders, psychotic, mood, anxiety, physiological, personality, intellectual disabilities, and developmental disorders. So we'll start off by having a general view, and we'll go into more details of certain diagnoses. So in 2019, the three main diagnoses that were admitted were those of substance-related disorders, psychotic disorders, and mood disorders. And these are represented in the colors orange, gray, and yellow. And when we look at 2020, we see some changes. We saw that the substance-related disorders that were admitted decreased. The psychotic disorders slightly increased, along with the mood disorders. And we will have a closer look at these three diagnoses, as they comprise of more than 80% of the diagnosis received for the patients being admitted. So the first look is at the substance-related disorders. And here we have two types of diagnosis: the substance use disorder, which also includes substance-related disorders in terms of substance-induced mood and psychotic disorders, as well as the alcohol use. And we see here that there was a decrease by around 57% of patients from 2019 to 2020. Moving on to the psychotic disorders, under this category, we have various diagnoses ranging from brief psychosis, schizophreniform, schizophrenia, schizoaffective, and delusional disorder. And I'd just like to concentrate on brief psychotic and schizophrenia, as they had most of the changes. And we can see here from 2019 to 2020, there was an increment in those receiving the diagnosis of brief psychosis, where there was a decrease of around 42% in those receiving a diagnosis of schizophrenia that were admitted in 2020. And the last bit here is the mood disorders. And here we can see two types of diagnosis: bipolar and major depressive. And the main change was in bipolar disorder. And here we see that around 74% increase from 2019 to 2020 admissions. And this brings me to the end of the preliminary results from our study. I'd just like to highlight that our results show the importance of preparedness and competency of healthcare providers, not only in managing psychiatric impact, but also in detecting it. And moreover, it is of an absolute need to develop future studies especially assessing similar factors in other inpatient psychiatric facilities, both locally and in the region. And this brings me to the questions that Dr. Madonna raised previously. What is the impact of the pandemic on psychiatric illness? Does it trigger an episode in a vulnerable population? And what does that mean to our community? And what can we do as healthcare providers to prevent and reduce the psychological stressors and impacts of future disasters? I'd like to thank you all for listening to us, and we're looking forward to the discussion. Thank you very much.
Conference to hear, we're going to jump across time zones, aren't we? And there are so many similar themes of things that we have learned so rapidly, aren't there? I'm sure in the future we're going to reflect back on this and just understand how much and how quickly we learned and adapted. Now, without much delay, because we're running a little bit behind, our apologies, I have the pleasure once again of introducing Dr. Aisha, who's joined on this occasion by her colleague, Dr. Iman Musa Al-Houti. Dr. Iman is a specialist psychiatrist and who's undertaken internship and clerkship coordination roles at the Sheikh Khalifa Medical Center in Abu Dhabi. She's an Arab board psychiatrist, and she qualified in 2016 with her Arab boards. So I'd like to hand over to Dr. Aisha and Dr. Iman, who are going to present live. Thank you.
disabilities were excluded, and neurocognitive disorders like dementia were excluded as well. After excluding those patients out of 1,439 visits, only 1,050 patients were included in the analysis. And the data included patients' age, gender, marital status, psychiatric diagnosis, COVID-19 status, type of visits, and the outcome. So in regards to demographic characteristics, we found that 55.9% were male and 44.1% were females, and it's correlate the gender distribution in United Arab Emirates. With mean age of 40 years, 57.5% were married. Marriage was equally more common in both females and male, and it was common with major depressive disorders, while patients with schizophrenia were either single or divorced. Arab were predominant, followed by Asian, African, and Caucasians. Regarding the DSM-5 psychiatric diagnosis, we found that the depressive-related disorders was the highest, the most prevalent diagnosis in our sample, with 32.7%. Then schizophrenia spectrum came the next with 26.4%, then bipolar disorder, 21.6%, and anxiety disorder with 13.4%, obsessive compulsive disorder with 4.6%, personality disorder with 1% only, and the least was gender dysphoria. And the prevalence of psychiatric disorders in the outpatient clinic in our facility was the same, and even compared to the pre-COVID-19 period. And our findings were similar to the international studies in regard to psychiatric disorders, frequencies in psychiatric outpatient clinics. And comparing to the study in same region, like in Saudi Arabia, we showed that the most common psychiatric diagnosis among outpatient clinics was major depressive disorders. The visit type, as you see here, the 98.4% of the patients were known to our service, and it was only 1.6%, like 17 patients attended the clinic as a new appointments. And it was compared to the 250 patients per month in the pre-COVID months. And the most common presentation was anxiety disorders, then depressive disorders, and psychosis. The visit type was classified to teleassessment and face-to-face assessment. 65% conducted teleassessment, while 22% conducted face-to-face, and 13% patients came for medication refill without conducting face-to-face assessment. The majority of patients who come for face-to-face assessment were having diagnosis of schizophrenia, then depressive disorders, then bipolar disorders. And this face-to-face, the 22%, it's including the new assessment also. So the outcome of the visits in relation to the type of assessment and visits, we found almost 90% reported to be stable during the assessment, 9% reported to be in relapse and subsequently required either change of medication or inpatient admission. And most of the patients was with mood-related disorders. 0.8 patients reported improvement of symptoms. And we've noticed that the relapse rate was higher in patients who were seen face-to-face. Regarding the COVID-19 test and the result, by April, only 89 patients had taken PCR COVID test, and only 2 patients tested positive in our sample. Majority of patients who took PCR tests voluntarily were having diagnosis of depressive disorders. The least diagnostic group that took the test were schizophrenia spectrum. And this could be explained by the level of awareness and the insight of people with severe mental disorder about the seriousness of the pandemics. A study in India showed 3/4 of patients with severe mental disorders were not worried about getting COVID-19 infection and lacks adequate knowledge to identify the symptoms. In conclusion, there was only a drop in the number of the new cases appointment, but not in the follow-up appointments. And it might be the reason behind that is the fear and avoidance of hospitals seen as risky places, change in the threshold for mental health seeking treatment, and the lockdown imposed by the government. The great shift in teleassessment, the service, home delivery of medications, and long-acting injections administered at home were the main reason for maintaining the service in the outpatient setting. People with the schizophrenia spectrum were the least to be aware of this pandemics. Thank you so much.
Thank you very much. That was really fascinating. A very important and interesting topic. We are going to go in next into our questions and answers session. I've been asked to request that people are kindly just a little patient because our colleagues who run the IT system for the conference have asked us to just wait 2 minutes, and they will refresh the screen and put up a holding slide. And when we restart in 2 minutes' time, the people who've kindly spoken, myself, will be there to take and understand your questions. So if there's any extra questions, please pop them into the chat, and we will see you in about 2 minutes to hopefully come back and answer those questions for you.
Just a minute. The back end is just preparing. Sorry about that.
In 1 minute.
Yes. We'll give it a go signal.
Okay, that's fine.
Okay, thank you.
So, Madonna, you were nodding there. Can we send you that question about, the relative stress being, organic or psychosocial?
Yes. We have reviewed some papers, so yes, I believe we can answer that question.
Brilliant. Fair enough. Wonderful. We'll see if others come in when we're talking. If not, we'll be able to stop and catch up the time with the conference timetable. I had a real struggle with that. I don't know yourselves, I wasn't aware that when people had a recorded film, we can't see it. So I had to quickly boot up a second device to actually see the two films. Did other people know that? No. It wasn't easy to chair when you're not seeing the presentations, but I watched them on my phone eventually. Okay, welcome back. Thank you, everyone. Some technical glitches there, getting things set up. Hopefully things will run a bit more smoothly as time goes on. So thank you, and thank you again for excellent presentations. We've been reviewing the questions coming in. There's some really good questions actually for Dr. Amna. Unfortunately, Dr. Amna couldn't join us for the live panel discussion. We were having a chat amongst our experts, and there's no one as expert on pain management, so I'm not sure we can answer those. I apologize to Dr. Huda. So I would say, and I'm not pretending to be the expert, there was a question: if a patient was diagnosed with MS, multiple sclerosis, and happened to be depressed, does this mean they should receive a higher dose of antidepressant medication to tackle both the pain and depression? My understanding that isn't the case. Ordinarily, you would titrate to a standard antidepressant dose and wait there, but I cannot pretend to have more expertise expertise, and certainly not that Dr. Amna would have. So I think we should move on to other questions. We were able to have a look at these and have a think about who might best answer them. If people want to send in other questions via the chat, we'll also flag those up. So the next question then is from Dr. Rima. It says, and Dr. Madonna is going to answer this for us. I've run into a few articles on the possibility that COVID in itself may cause different levels of brain damage, even in asymptomatic individuals. I'm wondering how much the new onset of psychosis noted in some countries is coming with the stress of the pandemic more directly than from possible brain damage. Dr. Madonna, if you want to unmute, that would be great.
Thank you, Dr. Rima, for the question. Lancet published in May 18 a paper that actually they were looking into COVID patients, and they suggested that there was higher rate of insomnia, anxiety, acute confusional state. But to your question, I think the only thing we can hope for is follow-up studies, because this is what will really show us if this was a direct causal effect of the brain damage of COVID, or it was the stress of the pandemic. This is what we saw in the literature review. This is what, as I said in the presentation, Carl Menninger during the Spanish flu question, that is whether the Spanish flu in itself is a direct pathological factor, or it's causing organic psychosis, which later when he did 1 to 5 follow-up study, 1 to 5 years follow-up studies, and it shows that the cases had remitted, I would say from the literature review, I'm leaning towards that it can be the stress, but we wouldn't know without a follow-up studies after the pandemic is over. So we know whether this is really stress or organic relation. In our study, we didn't check the rate based on whether the patient had COVID or not. So we cannot really say for sure, but definitely follow-up studies would help a lot to justify that. Again, I want to highlight that there are studies with other natural disasters that is not illnesses, like earthquakes, like wars, which again suggest a new onset psychosis. So we know for sure that stress can induce psychosis, but to your question, we need definitely follow-up studies in those patients who had been COVID positive before and had developed psychosis. So we need to see after the resolving of symptoms, how if they have still any signs of current psychosis going on. I hope that answered your question.
It sounded like a very thorough answer. Thank you. Really excellent. I was thinking as you were talking, there's a little bit of literature, isn't there, just describing and considering the impact that COVID's had on particular ethnic groups and Black people in particular. And I think there's a lot of feeling that, you know, clearly the psychosocial difficulties which affect people's health, which, you know, goes to what Dr. Amna was talking about, that the relationship between physical and mental health, that undoubtedly the psychosocial factors are really important. Dr. Aisha, it's going to be over to you, and we haven't had the same time to prep for this one, and you're popular with a few questions. So the first question, Dr. Aisha, is how is the COVID-19 pandemic affecting psychiatric services in the Emirate of Abu Dhabi? You touched upon this, of course, in your presentation, but perhaps you could summarize with some of the bullet points.
Yeah, thank you for the question. So, according to hospital data, we have observed a reduction in the emergency psychiatric visit and the number of admission. This is in the month of March, April, and May compared to last year, around 10% reduction. Now, when it comes to outpatient department, because we have outreach for patient, we played an active role to go and get patients and deliver medication to them and administer injection at home. So we haven't observed really a drop in the number of outpatient visit. If we consider teleassessment as a visit, as actual visit, there is no drop. The drop was only in the new cases new cases, new appointments, new referrals that have dropped significantly from 200, 300 patients to 17 only during April. And in the child clinic, new cases as well. And in the geriatric clinic, new cases as well. That was like a marked drop and reduction.
Hi, Dr. Aisha. We're going to keep you on the spot. People are very interested in your perspectives. So the next question, there's a multifaceted question, so I'm going to select components of it for the sake of time. So the first component of this next question is from Karine, who works at the college. She's a clinic nurse at the college level for women. I guess you might know what that means. Is there currently progress in regard to the budgetary allotment from the government in the field of mental health?
Is there a progress in what?
Progress in the budgetary allotment. You know, you talked about the amount of monies needed, and this, our colleague is wondering if there's any change. You may not know.
Yeah, I hope if I have the answer for this. I mean, the data is not always clear, and it's not shareable. And the one I had is back to 2010 and 2015. And again, the budget of mental health services is within the budget of general hospitals or general services. So you cannot say that no, this have increased now compared to last year or so.
It's interesting, as someone who's visited the UAE, and so I've been party to thinking about mental health services in the UAE. I always am really struck and staggered just how much the country has embraced thinking about mental health and making really important investments. I think I'm always impressed when I hear your leaders and your hospital leaders and your national leaders, just how much they've embraced the importance of mental health, and the scale and rapidity of change is totally unlike what we would expect to see, certainly in the United Kingdom. It's very impressive. So, Dr. Aisha, I was giving you a little breathing space there. Next quick question. This one might be a little bit more straightforward for you to answer. It says, is there a shortage of staff and healthcare professionals and allied healthcare workers in mental health care?
Yes. Compared to international benchmarking, we have 1.6 psychiatrists per 100,000 population. Compared to other countries, the lowest is 6 psychiatrists, and there are countries who have up to 20 psychiatrists per 100,000. So there is shortage. That's why we propose the integration with the primary health care to train family physicians and GPs.
It was an excellent idea. I really liked the pyramid that you presented. It was a really helpful way to sort of view that. I'm going to sneak in, as chair's privilege, just the last question from myself, again to Dr. Aisha, so sorry to keep putting you on the spot. I was just really interested in some of the metrics. It makes you want to move to Sweden, doesn't it, with all of those psychiatrists? It sounds almost heavenly. Anyway, back to UAE. Do you know at all what your average length of stay in your inpatient beds is?
Yes. Now, if you look into average, it would say, according to data, it's 11 to 12 days. But I wouldn't deny that some patients would exceed 30 days and some patients below 5 days. So the average is around 11 to 12, 13 days.
That's really interesting. And you were saying that at present you don't have the children's inpatient units. I think those figures would be similar for adults here, and children's stays are typically longer. It'd be really interesting when you develop your services from scratch, just how that pans out. I might ask you that question in a couple of years' time and think about that. So listen, guys, it's been brilliant. We've had a few technical glitches. I think we're learning on the way, but there were some excellent presentations. At least everyone got to hear all of those. I'd like to thank you for your attention. The conference now has the ability for our colleagues to have a quick break, but they can also look at the online poster presentations, and there's an exhibition area through the conference platform. I'm certainly going to go and explore that now myself. And I'd just like to thank all of our colleagues. If we're in the room, we'd be clapping. So thanks a lot. And it was really interesting and a brilliant start. Take care.
Thank you, Dr. Bro. Thank you, everybody.